The supinated foot is a complex presentation, often displaying a combination of pathomechanical function in the frontal, sagittal, and transverse planes. From the posterior view, this foot may present with the calcaneus trending from a vertical to an inverted position in the frontal plane, more convex malleolar curves, and toes visible more medially. From the medial view, the foot may present with a higher medial longitudinal arch, with the talar head palpable more laterally than medially. From the medial oblique view, the talar navicular region may appear more concave or hollow. Using plantar pressure analysis, this foot may present with a reduced plantar surface contact area and high heel and forefoot pressures. During sagittal plane function in gait, due to the more rigid foot structure and the lack of rear foot eversion, the supinated foot may present with poor shock absorption, leading to compensation in the proximal chain at the ankle, knee, and hip. Another common presentation of this foot type is a sagittal plane block at the ankle, or an ankle equinus, which is a decreased range of motion due to tightening of the posterior structures, including the gastrocnemius or soleus. During foot loading from heel strike to mid-stance, the foot may also present with lateral instability as seen by overactive perineals, prolonged loading of the lateral foot, and maintenance of a lateral toe-off pattern. The lateral toe-off pattern, or low gear toe-off pattern, is a sign of impaired propulsion and may also result in proximal compensations. On examination of the forefoot, the supinated foot can also present with several features. They include an adducted forefoot, a forefoot valgus, a plantarflex first metatarsal, or a forefoot equinus. A supinated foot can also present with many mistimed gait events. They can include the previously mentioned poor shock absorption, prolonged lateral loading, a low gear or lateral toe-off, and impaired propulsion and windlass mechanism. Your patient may present to your clinic with many pathologies relating to their foot posture and function, including various forefoot pathologies, including skin changes or hyperkeratosis, general metatarsalgia, metatarsal capsulitis, bursitis, neuritis, or neuroma, all relating to the high loading and high forefoot pressures and impaired forefoot function, especially during propulsion or toe-off. First MPJ pathologies are also common, including bunions or HAV, and the development of hallux limitus and sesamoiditis, all relating to forefoot loading, function, and instability. Toe deformities may also be a sign of impaired forefoot function, including plantar plate injury, claw toes, or retracted toes due to muscular imbalance. Arch and heel presentations are also common, including plantar heel pain, plantar fasciitis, Achilles pathologies, fat pad syndrome, and midfoot osteoarthritis, all relating to the foot loading and increased tissue stress demands. The lateral foot loading, lateral toe-off, and instability can all be related to presenting complaints including perineal pathologies, lateral foot pain, cuboid syndrome, and lateral ankle instability. Due to the proximal chain compensations previously mentioned and poor shock absorption, your patient may also present with common pathologies affecting the patella or patellofemoral joint, the knee joint, sacroiliac joint, and lower back. For daily education and training, follow us on social media, including Facebook and Instagram. Subscribe to our YouTube channel, follow us on LinkedIn, or visit dolaorthotics.com.